What's up? Today, we're going to talk about the nervous system. Our first part, we're going to review the anatomy and physiology, talk about some different functions, things to go over and remember. And then later, I want to talk about some other conditions that we can find, like demyelinating, degenerating, and motor neuron disorders, things that can affect our neurons and things that we're going to talk about a little bit. First, let's talk about the structures in the nervous system. Our first and main structure that we have in our nervous system is the central nervous system. So there's two main structures. This one is the central, right? Think your boss or your agency director or somebody that is the controller, right? So this person is directing how things are going. And they're saying that I want this to happen. I want all of our trucks to be in service. I want 100% compliance with our response times. I want to make all the money in the world. And so our bosses, our central nervous systems have the ideas and they say, this is what I want to happen, right? So our central nervous system, this is responsible for the thought, perception, emotion, and then of course those functions that we don't even think about, right? Like our heart rate, the variability that we need to maintain homeostasis, blood pressure management, digestion, all these things that are just controlled without us even thinking about it. So this is the big boss, right? This has the brain. So the brain's within the skull. This is the control center for most of the bodily functions. And then, of course, including the brain, within the brain, you've got the cerebrum and then the cerebral cortex. And we'll talk about those different lobes in a little bit. And then, of course, you got the spinal cord. So this includes like the brain stem and then the spinal cord, which is kind of acting as that like communicator pathway, which then leads us into the peripheral nervous system. So this is the other main structure in the nervous system. Now, I want you to think of the peripheral nervous system like email. So you have the boss, you have the director of your agency, and he has all these goals in mind. Well, how does he communicate all these goals that he has in mind? How does he communicate them to you, the neuron? So, what he's going to do, he's going to fire up his computer or his phone. He's going to open that like he does once a week. He's going to go on Outlook and he's going to send you an email and he's going to say, hey, I want this done today. And he's going to send that. Think of the central nervous system like your boss. Think of the peripheral nervous system like the email system. This is the communication pathway that's going to transmit all these commands from the brain to the body. You've got all these different organs, all these different muscles and tissues that are working, and the brain controls those, and it uses the peripheral nervous system to transmit those controls. So this transmits those commands and also receives feedback. And it says, hey, I was able to do this. Or, hey, I'm having a little bit of pain when I am doing this function. And so the peripheral nervous system, all these things that, such as nerves, so the nerves that are extending from the central nervous system, everywhere else, those carry the signals for neurons, right? The neurons themselves are, of course, the special cells that have the signals. Of course, you got the somatic nervous system. These are those voluntary movements of the skeletal muscles. And then, of course, the autonomic nervous system. Those are those functions that we don't normally see, right? But again, this is containing those nerves, the somatic nervous system, the autonomic nervous system, some ganglia, big fancy word. There's just a cluster of nerves outside of the central nervous system. And then, of course, neurons. So before we get into neurons, let's talk a little bit about the cerebral cortex. So we talked about the brain. Let's break those parts of the brain up into fours. Now there's actually five, but it's not really shown. Starting off with the frontal lobe. most of you may not even have developed yet. But these are those higher cognitive functions: the conceptualization, the planning, the problem solving. This is that bachelor's in disaster management that gives your director all those knowledges on what to do. There's all the problem solving, memory, emotions, all those things. Now, there's a part that you can't see here. This is the insula. The insula is really beneficial to processing information from those external receptors. It gets the feedback. This is the Microsoft form from the employees. And it says, hey, we like what you're doing. The insula takes that information and it gives that to the brain and says, hey, seems like everybody's going good. And it's also responsible for taking that feedback and saying, hey, uh, our body's a little hot. We need to cool down. Start shivering. Hey, we have an itchy part. Itch it. Hey, I'm feeling pain somewhere. Hey, ooh, I just ate something and I really like the taste of that hot dog. Or I'm hungry. I need to eat more of that hot dog. I'm thirsty. I need to drink more hot dog flavored water. And then, of course, it senses the body's position in the current space that you're occupying. Of course, next you got the occipital lobe. Now, if you couldn't guess, occiput, whatever you say that is, that's just processing and perceiving the visual information obtained from the eyes, from the optic nerve and such. The parietal lobe. This is processing a lot of information from the sensory nerves, the skin, joints, all those things. The insula takes a lot of that pain and temperature management and gives it to the parietal lobe and says, yo, do this, manage this. The temporal lobe, so this is the higher order visual information, speech comprehension, and a lot of memory formation happens here. Now let's get into the brainstem. So we talked about a lot of those big lobes. There's the insula that you can see. It is now pictured. Now let's talk about some brainstem stuff. Now here we have the brainstem containing the midbrain, the thalamus, the pons, the medulla, all those things. I want you to think of the brain like a relay. So the brain is, I say brain, brainstem. The brainstem is the relay from the brain to the spinal cord. So most of this stuff is relaying that information and delivering it to the appropriate, part of the brain. Now, the only exception is the medulla oblongata. The medulla helps regulates and control breathing, heart rate, blood pressure, reflexes, coughing, sneezing, vomiting, and that connects it to the spinal cord and helps deal with those issues. Midbrain, again, is relaying that auditory and visual information. The thalamus is regulating a lot of sleep and what else? Yeah, cool. The pons. Now the pons. This is a big one. This relays sensory information to the cerebellum. So the eyes, facial expressions, breathing. The medulla oblongata. Again, this is an important player because he's regulating a lot of the breathing, the heart rate, blood pressure, and all those reflexes that we otherwise may not think of. And then, of course, the spinal cord, that's running from the brainstem down through the back. This is the communication highway. This is I-40. It's taking all that information from the brainstem. It's going down the spinal cord. It's going through the body. And then those responses will travel up the spinal cord and then go to the brainstem and then distribute amongst the proper parts in the brain. Okay, now let's talk about the neurons. This is a special cell. This is super special. The most special cell you'll ever know. Now there's different types of neurons, right? Think of neurons like ears. So this is listening to the feedback that your tissues have. And it's saying, ooh, I have a message. I need to deliver this to the brain. Now the neurons are the message. The nerves are the highway that the neurons take. So the nerves aren't really doing much of communicating that message. It's just allowing the message to be traveled up to the brain. Now there's a few different neurons. we've got sensory neurons. These are neurons that detect stimuli, light, sound, pain, all those things. Motor neurons. These transmit from the central nervous system to muscles and glands. The motor neurons are what causes contraction. The motor neurons are what causes contraction. So these are transmitted from the central nervous system, and then they tell stuff to contract. That's all it's doing. It's just saying contract. And then, of course, interneurons. These are the connection between the different neurons. Now, this is the cell body. This is the central part that has a nucleus and other organelles. And this provides the neuron with energy. It helps maintain its structure. And it helps all the other things like the dendrites are the extensions that receive signals from other neurons or sensory receptor sites. So those little fingers go in there and they say, ooh, what senses do you have? And then it travels into and towards the cell body so that the nucleus says, whoa, we got a message. We got to deliver that. The axon, the axon. This is a long, slender projection. It carries signal away from the cell body. So these are insulated by myelin sheaths. So these signals are important and they need to be insulated. And so those myelin sheaths help protect the axons and that communication from traveling down the terminal. The synapse. Yes, the synapse is the junction where another neuron communicates with another neuron or the cell that it's trying to act upon. Now, of course, you got the myelin sheath. That's that insulating protective layer. It's covered in fat and it's protecting the axon so that it can transmit and target other neurons, either to other neurons or the specific receptor site. And then, of course, you got the axon terminals or synaptic terminals. And these are those special structures at the end that transmits those signals. So the axon delivers that to the axon terminal where it then gets delivered. Now, this is important. I want to go over cranial nerves. Now, it is important to understand this so that we can see what is affected in our patients when they have deficits in this. So cranial nerve 1, this is our olfactory nerve. Now I color coded this so that you can tell which nerve is which. This is a sensory nerve, and it's responsible for smell. So cranial nerve 1, olfactory, this is smell. Cranial nerve 2, optic. Of course, this is a sensory nerve, assessing vision. So it takes all those visual inputs, and its job is to assess and sense vision. We're going to switch up that color to a motor neuron, ocular motor. If you couldn't tell by the name, it's a motor neuron. Mind blown. Now, this is responsible for most of the eye movement, except moving inward. Now, I know what you're asking. But if the ocular motor nerve doesn't move the eye inward to look at the nose, which cranial nerve does? And I'm so glad to report the trochlear nerve moves the eye inward towards the nose. Oh, this is crazy stuff. So cranial nerve 4, trochlear, this is a motor neuron. This moves the eye towards the nose. Cranial nerve 5, like GTA 5, the best game ever, like 13 years ago. This is the trigeminal nerve. Now, we're going crazy here. This senses and does motor functions as well. What does it do, you may be asking? This is responsible for face sensation and mastication or chewing. Crazy. Next, cranial nerve 6. This is the abducens. Abducens. This is a motor neuron, if you couldn't tell by the green color. And this is abducting the eye. I know, so concerned about eye movement. This is abducting the eye. Cranial nerve 7, take it away. This is both sensory and motor. This is facial expression and taste. The facial nerve, cranial 7. Right, cranial nerve 7. This is the facial expression, taste. These are all the things that this cranial nerve is doing. My hand's cramping. Next up, we got a sensory vestibulocochlear. Vestibulocochlear. Good luck saying that 3 times fast. Now, this is a sensory nerve, and this is mostly collecting information from going to the big red. We got both sensory and motor. This is the glossopharyngeal nerve. What? This does both sensory and motor. Can you guess what this nerve is responsible for? Taste and gag reflex. Look at that. Now, this is a big one. This is a big cranial nerve. Cranial nerve 10, or the vagus nerve. Ignore my spelling, I spelled it right. Yep, we're just going to go ahead and erase that. Cool, yep. US, cool. Now, this is the vagus nerve, both sensory and motor. Now, this is where the parasympathetic nervous system innervates. This is also gag reflex. So when you trigger somebody's gag reflex, you're also triggering the parasympathetic nervous system. Isn't that great how our body designed itself? Awesome. Next up, another motor neuron. Finishing up with 2 great motor neurons. You got the accessory motor neuron, or motor cranial nerve, geez. Now this is responsible for the shoulder shrug. Big ups, shoulder shrug. And then of course, cranial nerve 12, another motor neuron. Stop saying motor neuron. Motor nerve, hypoglossal, is responsible for swallowing and speech. Swallowing and speech. Now, this is a lot to remember, so we can remember this with a cranial nerve mnemonic. What? That's so crazy. So, if you're ever trying to wonder, like, ooh, I don't really remember the cranial nerve, or what cranial nerve 4 is, or cranial nerve 7 is. Here's a helpful mnemonic to remember. Ignore my spelling. That we can remember to say, hey, you know what? If you can't remember the order, say this mnemonic, and maybe you can help find um, that cranial nerve. Now, there's an old saying that we use to help remember the cranial nerves, such as "oh oh oh," to touch and feel, very good velvet, such heaven, or olfactory, optic, ocular motor, trochlear, trigeminal, abducens, facial, vestibulocochlear, glossopharyngeal, vagus, accessory, hypoglossal. What? That's crazy. Now, what if you wanted to remember the function of the cranial nerve? So you can remember that cranial nerve 5 is the trigeminal nerve, but oh man, I just don't remember what the function is. Well, here's another helpful mnemonic that you may be able to use. Sorry, my spelling's really bad. To help remember the different functions. Now, when patients are having strokes, it is kind of important to understand what part of the brain is being affected, and by knowing these cranial nerves, we can kind of narrow in on where that damage is. I also say that how is this going to benefit you in the pre-hospital setting? Dog, I don't really know. So functions. Some say my mother bought my brother some bad beer. Or sensory, sensory, motor, motor, both, sensory, both, motor, motor. In the same order as the other cranial nerve mnemonic. Man, we are so good. We are so back. So that's a helpful mnemonic to remember the cranial nerves. Now we're going to get into my favorite section. We're going to talk about demyelinating, degenerative, and motor neuron disorders. So, three types of diseases that do have very similar presentations. And often, if you didn't discern between the three different categories, you may just get confused that it's all one category. And let's talk a little bit about this. So, demyelinating, this is in the name. It is damage to the myelin sheath, the thing that's surrounding the axons and that kind of insulate and protect that smooth signal transmission from neuron to neuron. This is damage to that myelin sheath. This is affecting that signal transmission, which kind of makes everything less efficient. Degenerative. So backing up real quick, demyelination. This is damage to the protective sheath, not the actual neuron. Degenerative. These are the progressive damage or death of the neurons. So, not necessarily a kind of demyelination of it, but typically damage or death of the neurons. Now, unfortunately, these conditions necessarily aren't curable. So these are progressive deaths that we can't really prevent against to the motor neurons. Oh, can't really draw. There we go. And then, of course, motor neuron disorders. These are typically the destruction of motor neurons. So, demyelination, degenerative, these can be both sensory, sometimes motor, but motor neuron disorders, are destruction of the motor neurons. So these are typically presenting with those progressive difficulty with speech, ambulation, movement, and then later those autonomic functions. All right, cool. So let's get into some specific conditions. First, starting off with multiple sclerosis, or MS. Now, this is an autoimmune condition in which the body attacks myelin sheath in the brain and the spinal cords. What? This is crazy. So the body's immune system, typically this is believed that T cells are released into the central nervous system. Oh no! And this attacks myelin sheath by releasing chemicals and trying to think it's a invader, and it's really just the myelin sheath. And it causes the damage to the myelin sheath. And then later, the destruction of the myelin, which that's how it gets the name, demyelination. So of course the bodies, they can't really differentiate which cells are theirs and which cells aren't theirs, and then it goes crazy. Now, because of this destruction, and because of how damaging it is to the myelin sheath, the transmission of neurons are slower, takes more energy, and they're not able to process kind of information as fast as it normally once was. So it creates gaps in the myelin sheath. It's not as protected, and so you're asking, okay, this is a neuron. How does this typically present in patients? Well, MS kind of follows a pattern of episodes and remissions. So think of it like there's an initial episode. Typically, there's inflammation in the optic nerve and there's some double or blurred vision. And then later you get some prolonged symptoms, muscle weakness, impairment of pain. They can't really feel pain, poor sensation, touch, temperature regulation. And then you get into, the visual disturbances, bowel dysfunction, the cognitive abnormalities and fatigue. And then some also report like an electric sensation going down the spine or their extremities when the head is flexed forward. So it's kind of an episodic disease where things get better and things get worse, and they have all these different symptoms that they can present with. So again, these episodes can be brief or prolonged depending on the patient. We'll talk about all the different pre-hospital care and what we need to do for these patients at the end. I feel like we can summarize it to one. Guillain-Barré syndrome, or GBS. So this is a rare disease where the immune system is attacking portions of the nervous system, typically the peripheral nervous system. Now, not just the peripheral nervous system, but this is specifically targeting the axons and the myelin sheaths in the peripheral nervous system. So some sort of infection happens. Some infection happens, and that cell looks like the axons or looks like the myelin sheath, and it has that same structure to it. And so all these antibodies are coming in and going, hey, that's him, get him. But it's actually the axon and myelin sheath instead of being some disease. And this results in the axons and myelin sheath being attacked. Now, this is where it gets a little concerning. This is an acute infection, right? An acute reaction to an infection. So Guillain-Barré syndrome isn't something that is typically progressive. This is an acute exacerbation of the immune system. And so the attacking of these axons typically happen very quickly. So initial onset, what are they going to look like? Typically, they're going to have some weakness and tingling in the legs, right? This is going to impair sensation and function in the extremities. Now, as this gets worse and as it progresses through the spinal cord, this is going to move up to the thorax, to the chest and abdomen, and eventually up to the arms. Weakness can worsen. Now, this gets up, and eventually it could lead to paralysis. So that, depending on how severe this attack on the myelin sheath is and the axons, this can lead from just the initial weakness and tingling to paralysis. We can also have the severe swings in blood pressure and heart rate due to the autonomic nervous system. Now, again, this is something that can happen within several hours. It can happen from, oh, my arms and legs are feeling a little tingly, to they need mechanical ventilatory support. So something to keep in mind with GBS is that the condition typically worsens, not typically, the condition can worsen within hours of onset. Moving on to Parkinson's disease. So Parkinson's disease is a neurologic condition that damages those certain neurons. So there's a portion of the brain, the substantia nigra. Now, this is responsible for the production of dopamine. So dopamine gets produced in this area of the brain, and what dopamine does is it helps muscles contract smoothly. Huh, bet you didn't know that. Dopamine helps muscles contract smoothly. When this portion gets damaged, well, what do you think happens? Yeah, dopamine gets produced less. So skeletal muscle, more likely than not, needs dopamine to smoothly contract. When this is damaged, well, of course, then the smooth muscles don't contract smoothly. Now, it can be caused by a lot of genetic factors and environmental reasons, like pesticide exposures, pollution, and a lot of other factors. What does this look like? So this is typically a gradual onset of symptoms over months to years. So this is something that's going to happen over time, typically onsetting with unilateral tremors, postural instability, and even bradykinesia, or slow feet shuffling movements, small steps to turn while walking, examples of bradykinesia. Of course, there's a relation with the dopamine levels. The more that this area of the brain is damaged, the more the levels of dopamine falls. Of course, as more dopamine falls, more areas of the body are involved. Of course, because of it being a motor neuron disorders, more areas that are affected, of course, higher risk with aspiration, aspiration pneumonia, immobility are definitely huge concerns with Parkinson's. So again, the more those dopamine levels fall, the more areas of the body are going to be involved. ALS, or amyotrophic lateral sclerosis, or Lou Gehrig's disease, whichever one you prefer. Now, this condition is attacking and causing the death of motor neurons. We don't really know how it's actually happening. A lot of things believe that it's due to an immune response similar to other conditions. It's more common in middle-aged men, any race, or but more commonly middle-aged men. So as we're looking at ALS, what does this typically look like? That typically starts with a gradual onset of fatigue. Again, very similar presentation with these diseases. I actually get confused with which condition belongs in what group. But typically, this is a gradual onset of fatigue, some weakness, maybe some muscle twitching, and then eventually difficulty doing those daily routine activities. And as this progresses, this can affect mobility and gait. And so they can't walk, they can't move their arms, they can't eat, they can't speak. Um, Now, again, this is something to note too. With all these conditions, this is only affecting motor neurons more than likely. And so they will still have consciousness, they'll still be aware of their surroundings. However, they won't have the ability to speak or eat or walk, but their brain is still firing. The deputy director, the director is still in charge. But Microsoft Outlook got shut down. They can't communicate those things, but they still have cognitive function. Now, let's talk about pre hospital management. Of course, common sense stuff, right? We want to manage those life threatening conditions that when we approach these patients, we may have to manage things. So, of course, maintain their airway, maintain ventilatory function, make sure that they're able to breathe, make sure that they have an open airway. Of course, next, we want to maintain those vital functions. Now, because of these diseases affecting those sensory and motor neurons, this can affect heart rate and blood pressure. And so we want to assess for those signs and make sure that the heart rate's not too low or too high and the blood pressure is not too low or too high. We can support that with IV fluids. More than likely, these patients may be dehydrated. And so providing fluids will definitely help with their blood pressure, maybe bring down their heart rate. And of course, another thing they could be experiencing is pain. So pain management is definitely going to be huge when we're treating these conditions. Comfort care, pain management, these are all huge things. And of course, transporting to the appropriate facility. Of course, doing that thorough assessment, ruling out those life-threatening conditions, and getting them to the place that they need to go. Guys, I think that's it. I think that's all I have. Thank you.
Dude, sweet. Thanks for watching. Appreciate it if you actually watch these. I spend a lot of time on these, so thanks. Appreciate it.